all for having me. Just a brief introduction about myself. I'm one of the new attending vascular surgeons over at Temple. I am not necessarily new to vascular surgery. I've been a vascular surgeon for 7 years now and a general surgeon for a few years before that. So I developed an interest when I was doing my training at Baylor at neurogenic thoracic outlet syndrome in particular, and thoracic outlet syndromes in general. Today we're going to talk more about neurogenic thoracic outlet syndrome because I think that it's particularly salient to you all because it's going to, oh, right, wait, hold on. I'm being recorded for posterity apparently. Can you hear me okay? All right, great. So, neurogenic thoracic outlet in particular, but again, the gentleman who trained me in the name of Greg Pearl, Dr. Greg Pearl, used to do nothing but professional athletes essentially. Many people who would drift through the office who I would look at him and say, I know that guy, right? Isn't that Mr. Professional baseball player for somebody or another? And he said, yeah, that's it, but you can't ever use his name because of HIPAA violation. So, yeah, I'll keep it on the down low. That's where I sort of developed my interest in this sort of oddball pathology for us, but it's something I happen to enjoy, and hopefully at the end of this lecture you will too. So as far as disclosures, I'm not getting any cash for talking to you, okay? And I have no major financial relationships, but I did take a banana. So, consider that payment if you will. All right, so a little bit of background and I'll be brief. All right, so Galen. Galen was a Greek anatomist and court physician to the Emperor Marcus Aurelius of Roman times, and he described the first cervical rib about 150 years BC. Sir Astley Cooper, who described thoracic outlet syndrome in a young woman with arm ischemia after she developed what was called a post-stenotic dilatation, and we'll actually take a look at one of those later, described that relationship between compression of the subclavian artery and the what was found to be a cervical rib. This is these gentlemen, and to the right is Galen. Maybe you look like that. It's a distinguished picture. Sir Astley Cooper, obviously quite distinguished. He looks like that. Now, my colleagues will probably remember me something like this. So I like to think of myself, and try and take myself as seriously as possible, but that's at the end of the day what you're going to get. So we talk then about several of the types of thoracic outlet syndrome, and we talk about the things that you get at least as general surgeons and vascular surgeons, which you hear about in the books, and then what you're going to see every day. Vascular and venous are the ones we all talk about. The presentations are spectacular with the vascular arterial embolization to the arm. You have critical ischemia of the arm. You run off to the operating room and you fix it, and hopefully everything gets great. Venous, you have a huge swollen arm, and it's a outlet obstruction, which we will describe a little bit later. And you go off to the operating room, you fix it, everything is great. And then there's this neurogenic thing, where these patients come in presenting with these bizarre complaints, having been seen by multiple providers. And although it's not sexy, it is definitely the bulk of the work that's done in thoracic outlet syndrome, and it's where I make my particular niche. So as to neurogenic thoracic outlet syndrome, it really refers to this constellation of symptoms that you get from basically compressing the goods as they exit the chest and enter the arms. It is insidious, it is nonspecific, and it's caused essentially by probably a wear and tear phenomenon that we'll sort of discuss later and touch on. And like anything, it's probably that you have to have a couple of things. You have to be predisposed to it for any number of anatomic reasons, and then you have to have the certain set of life circumstances that will enable that predisposition to come to fruition. And again, we'll talk a little bit more about that. But what I've found with these patients, especially the ones I end up taking to the operating room, is that they've gone through a myriad of providers, had surgeries in some cases, gone through physical therapy for other cases, directed towards any sort of malady that you can imagine. And as you can imagine, they're extraordinarily depressed, frustrated, angry, because this is a real thing, and it causes a lot of problems. Now, etiology-wise, 3 to 80 in 1,000. I think it's probably, whenever you see a number with that kind of range, it just means you have multiple studies with multiple numbers, okay? And probably it lies somewhere in between. I think it's much more common than people give it credit for, but I don't believe it's as prevalent as 80 in 1,000 people. Otherwise, there'd be a bunch of people in this room who I'd have to see in clinic later. But at any rate, neurologic is female to male ratio is about 3.5 to 1, so you actually get a lot more women presenting this than men. And the usual onset of symptoms is 20 to 50 years old. It's a disease of younger folks. As to the causes, there's anatomic and trauma. Anatomic, we'll look at the anatomy of the thoracic outlet here in a bit, and I'll show you some of the pictures as to what that outlet looks like. I think you're all probably somewhat familiar. But the trauma can come in a couple of flavors, and often when you're discussing these folks, their history, they'll tell you that, oh yeah, I had this whiplash injury 5 years ago, and oddly enough, I don't know, my problem seems to have started shortly thereafter. I had a woman once who actually was hit in the shoulder with a snowboard, and a year and a half later, she had symptoms so bad that she actually lost half of her grip strength in her affected hand. She actually got better with the decompression, but again, it's that history of injury that seems to be more prevalent than not. So about the anatomy, cervical ribs, and we've all heard of cervical ribs. We're granted 12 thoracic ribs, and every once in a while, one of us who's a throwback or for whatever reason will have an actual cervical rib at the last cervical vertebra. Most of the time they don't cause any problem, but interestingly enough, with people with neurogenic and especially vascular thoracic outlet, they often do. And in fact, we know that the incidence of cervical ribs is very low in the population. It's 1 in thousands, but about 5% of people with thoracic outlet syndrome of any variety will have a cervical rib. So it pays to look for one when you suspect this, and it's very easy to take a look for. It's just a plain film, and we'll look at that later. Congenital muscular bands, we actually find these a lot in operation. They're these dense fibrous tissue bands that will cross the thoracic outlet. Sometimes you're born with them, sometimes they're the result of inflammation. Because when we take the anterior scalene and resect it, and if you do electron microscopy on it, you'll actually find that these folks have profound damage and fibrosis of these muscles as opposed to controls. Sometimes you can have what's called a scalene minimus, and we'll describe that here in a second. I've got a nice picture of it. Sometimes you can even have an elongated transverse process of C7. As far as the anatomic borders of the thoracic or of the outlet itself, some people will describe this in 3 pieces. I've found that, at least for the relevance for my particular field, it's 2. You first get the interscalene triangle, which is bordered by the anterior scalene. If you can imagine it sweeping down anteriorly, if you remember your anatomy, the vein is anterior to the anterior scalene. You get the anterior scalene. You get the posterior to that down. You get the vasculature, or I should say the subclavian artery. You get the brachial plexus, the trunks of it anyway, passing through posterior to the anterior scalene and anterior to the middle scalene. And then the floor of this is the first rib. And the first rib is sort of shaped like a plate, and it sort of sweeps down. And I've got a cartoon of it here. So that's the interscalene triangle. A little bit lateral to that is the subclavian space. And the subclavian space is actually, I don't think it sort of gets the credit due to it, but it's underneath your clavicle and below or above and lateral to the first rib. And you've got actually a fairly significant area of narrowing there. And in young men especially, you can have what's called the subclavius muscle, which doesn't really do anything for us, but it's actually quite robust in some cases and can cause compression of the vein. Let's see. Okay, so here's the promised cartoon. I'm going to try and use a little pointer here to point these things out. So here's the anterior scalene, middle scalene. The first rib is sweeping down underneath them. And you can see that the vein is anterior to the anterior scalene. The artery is posterior to the anterior scalene. I know you're throwing these terms around, it's like word salad, but you know, this is where these things sit. This lateral view shows it nicely as well. And this little guy is the scalene minimus muscle, which I've found on more than one occasion. And it just kind of sits there originating from C7 and inserting onto the first rib. These are just some anatomic variations. I'm sure you're all familiar with Frank Netter. He happens to be my favorite anatomist of all time, and he in fact died of an aortic aneurysm, and it was a misadventure with an aortic aneurysm. I'll tell you that story some other time maybe. But at any rate, he did do these beautiful drawings, and these are just some anatomic variants. This shows your cervical rib, which it usually has a couple of variations when it inserts itself into the first rib. It can either be this bony junction, which we find sometimes, but it seems more often that it actually has a fibrous connective tissue band that connects the distal aspect of the first rib in sort of this blade-like band down to the first rib. And it can cause, as you can see here, some compression of the artery. Arteries don't like compression and they don't like turbulence, so when you get those two things in an artery, Beyond the point of compression, you get a dilation of the artery and sort of compensation for the turbulence. We call that post-stenotic dilatation, and that can lead to significant arterial problems. This is more along the lines of what we're talking about over here. You can see that the cervical, the brachial plexus, especially, and remember those inferior roots here and trunks, sit right on this thing. And it can cause a significant amount of irritation. This is a little, I hope never to see this. It's called the rudimentary first thoracic rib, and what it does is just sort of bump the whole plexus down. And interestingly enough, in operation, when I'm identifying the roots C8 and T1, I know what I'm looking at because they actually straddle the first rib down here. So if you don't have that relationship, it's sort of like, huh, okay, what am I looking at now? And it can get a little interesting if you lose that anatomic landmark. So far as trauma, we talked a little bit about it. Now, again, accidents, nice if you can point to something in their history that they can say, oh yeah, I got hit in the shoulder with a sledgehammer. Okay, got it, right? That's easy. But more often it's not. And in the world of workers' compensation, which is a lot of these patients, it's more insidious. And when I actually have in my office a box full of books, and when I'm actually asking patients to come in and say, well, I'd like you to reproduce the symptoms, if they are a blue-collar worker type and they start stacking this box up and down, and it seems kind of silly when you're looking at this guy doing the same thing in the hallway, but if they reproduce their symptoms, it's just sort of repetitive trauma that can cause neurogenic thoracic outlet, just because of sort of this continuing, narrowing of the outlet and this crushing of the trunks of the brachial plexus as they pass through. One of the more interesting cases I ever did was a woman who was a professional violin player, and she had been crunching her left hand. And as if you've ever played the violin, which I don't, it's entirely dependent on that hand that's holding the violin. So if you can't move the fingers of that hand and you can't be very dexterous with it, you could go play for someone else, but you're not going to play in the orchestra. And that was her case. And when we fixed her problem, she got better, and she still plays, at least I think, to this day. Remember, these traumas may be remote. Now, because everybody likes to, it's tired and we're all eating and stuff, I like to throw in a little bit of interesting stuff off topic. So I'll take these dives in. Now, I used to be in the Army, and I was in the Army for 15 years. I finished up as lieutenant colonel, and we parted ways amicably. But I did have some interesting experiences, and this is one of them. What you're looking at is the beautiful view from Talil, and that was a small outpost in southern Iraq. The sky looks a little red, and that's because it is. We're in the middle of a sandstorm, and that's what they look like when you're on the ground. It doesn't look like the Hollywood pictures where the sand comes in and erases the skin off your face. Okay, it just kind of gets all red, and that's what it looks like, and it just sort of adds to the general misery of the area. And that was the view from my bunk. Okay, so there you go. Now, also, when I first got in and we flew into the main airport at Baghdad, it was called Sather Air Force Base at that point before we turned it off. But what you're looking at is one of Saddam's old airplane bunkers, and it was thought to be, at least by the people who built it, I'm sure they were telling Saddam, oh, it's great, it's going to work well, no problem, planes will be safe. And of course, we dropped our JDAM munitions on them, and they just bunker busted the things and blew up all the planes. And what you're left with is these things all over the city and state, which are, these mushroom things with giant holes on top. So I always thought that was interesting. And that's what became of the Iraqi Air Force before we built it up again. Now, so far as presentation for these folks, they really come in sort of two varieties, lower plexus distribution and an upper plexus distribution. Now, I'm not going to go through the entire layout of the brachial plexus. It's a bit beyond the scope of this lecture, although I think in your given profession, you'll understand it much better than most vascular surgeons will, I hope. But in my business, since I do this work, it pays to know, what nerves control what. But really what we see is the lower two nerve roots are the most common presentation. And that's, you can imagine, they're sitting over the area of maximal compression. And these patients will come in most commonly with the C8 and T1, and they'll get this pain and paresthesia in the ulnar nerve distribution. So they'll lose sensation in the lateral aspect of their hand. And if you can remember, the ulnar comes in laterally, sweeps into the hand, and it controls some of the lumbrical muscles of the hand, and the sensation for the lateral aspect. So, you know, that can be fairly significant. The second pattern is more of the upper motor neuron distribution, which can be a little more hard to pick up, but often these patients will complain of symptoms that are referred to the neck, ear, and chest. And then the outer nerve and then the radial distribution. And in fact, I took care of a young man who was hit in the shoulder by an MRAP patch, which is about 400 pounds, who actually had a musculocutaneous palsy that was horrible. And he had that, and he had a median nerve palsy, and he actually lost the ability to flex his biceps, and he couldn't use the grip of his hand because of the thenar eminence was knocked out. And he got all that back, fortunately, so we were very happy about that. So what do they complain of? Occipital headaches, anterior chest pain, pain in the medial aspect of the arm, the forearm, the digits. You have paresthesias, nocturnal awakenings when they shake out their hand and they can't move it because it's numb and has lost sensation. They lose dexterity in the fingers and the hand. Often they'll say, yeah, I'm sitting here and I can't, I'm holding the cup and I drop it and it just falls down to the floor. And they can get these very odd Raynaud's variants where they get a unilateral Raynaud's phenomenon, which is just basically a jacked up, you know, sympathetic response because you're compressing the nerves, and it really kind of plays havoc. So whenever you have a patient with a unilateral Raynaud's, suspect that they may have a neurogenic thoracic outlet. These are just some of the symptoms from Sanders, who studied about 1,000 of these patients, and it sort of broke down the symptoms that they presented with. And as you can see, everything we talked about is actually fairly prevalent when you're discussing these guys. As to the history, just ask about those symptoms. Always inquire as to trauma. Always be sure to ask about the contralateral arm, because, you know, these patients may come in with symptoms in one arm, but oh, lo and behold, they actually have some problems in the other. And if you catch it early, you can direct them to physical therapy, and you can actually make that better before it becomes a serious problem. Have they had previous surgeries? Very often they'll come in with slap tendon repairs or shoulder scopes or any other type of thing. I'm not saying that was the wrong thing to do. Clearly, you know, people thought, yeah, you got this problem. Maybe that was contributing to the problem, but often the surgery didn't make the condition better, and they come in having had an operation before. That's not at all uncommon. Oh, and of course, did they receive physical therapy, and was it directed towards thoracic outlet syndrome? Because as you know, there are many varieties of physical therapy out there. So on your physical exam, what I always have the patient do is take their shirt off and just sit and look at me. Do they have asymmetry? In other words, are they splinting? Okay, sometimes the pain is so severe when you sort of stretch the plexus that they actually splint and favor that side. It's fairly impressive when you see it. Sometimes you can see atrophy in the muscular groups in very advanced stages. Do they have plethora? And we have a picture of plethora, but really what that is just sort of a fullness of the chest with crossing veins, which is sort of a compensation for a narrowing of the subclavian vein. Is there a bruit in the supraclavicular space? There should never be a bruit in the supraclavicular space. So if you listen and you hear a bruit, that's an indication of a problem. Supraclavicular tenderness, palpable bands. Okay, so when you're pushing here on their supraclavicular area, do they jump off the table? When you tap into your Tinel maneuver, do they experience a shock-like sensation down the arm? All right, it's definitely indication of irritation of the roots and trunks of the brachial plexus. And it can also help you differentiate a central core phenomenon for like a spinal compression from a more peripheral phenomenon. Look for weakness. It can be quite subtle. Always do a neuro exam. It doesn't necessarily have to be a 50-point neurologic examination, but certainly make sure that their gross strength and sensation is intact. Is there a pulse difference? We all put a lot of stock into Adson's maneuver. When we do that, by the way, many people have turned the head away, but if you remember how the sternocleidomastoid muscle works, all muscles shorten to move. If you're asking a patient to turn their head away, these muscles are actually elongating and these are shortening. So it's actually the opposite side that's being compressed. Ask them to look towards you, grab the arm, be careful please. A lot of them have a lot of pain when you do this, and slowly work it out to the side as they're looking at you. Now, a word of advice. Have them look at your tie, okay? Looking in the eye is a little bit disconcerting when you're moving on the arm and you feel a little weird. So I'm just throwing that out there for you, all right? So there you go. These are just a series against Sanders with these physical exam findings. And as you can see, again, they're all fairly prevalent. Okay, now, this is the nectar of the gods. It's a Diet Mountain Dew. And I will give this to anyone Anyone who can name this physical exam finding for me. And it's not, you know, there's actually someone named for it. It's not hypothenar or thenar eminence. We know that. What is it? We should have some Jeopardy music. All right, Giat Sumner hand, mine. Okay, so this is what you see as plethora. All right, so plethora are these fullness of the chest and these crossing veins that just sort of make up and compensate for an occluded subclavian system. So additional physical exam tests. Always do a ulnar tap and always do a Tinel, because these patients, even if they do have a thoracic outlet problem, they may have a double crush. In other words, could they in the antecubital tunnel compression of the ulnar nerve as it passes by? Could there be a compression of the median nerves as it passes underneath the retinaculum? I mean, you can have these things and thoracic outlet, or you can have only these things. And often I'm referred patients who have that simple thing, and I refer them to my orthopedic surgeon. They do a carpal tunnel release 15 minutes later, and the patient gets better, and that's a good thing. So remember that the people who are referring these things to you, they may not know to look for them. And that's why I always tell people, send me these folks and I will sort it out for you. The East test, again, is, I think it's a very good provocative maneuver, and it's really the only one that I rely on, elevated arm stress test. And what I have my patient do is I'll start the clock, and I'll have them raise their arms up and start squeezing their hands. And if they start to get tingling or numbness or weakness or burning or whatever sensation or problem that they came into the office with, we consider that a positive East test. It's truly positive if it's less than 3 minutes, and we find that these folks actually are quite routinely less than that if they really have the real deal. So far as studies, my boss, Dr. Pearl, would require one study and one study alone for thoracic outlet syndrome, and that would be a chest x-ray. That was it. That's all he wanted. All right. Now, patients would come to him with all kinds of studies, up to and including EMGs, which we'll talk about in some detail, MRIs, CT scans, even myelograms. I mean, you name it, they had it. He said, look, you have a good physical exam, a good history. You figure out who's got this and who doesn't. And I'm really coming more to believe that, even though I will still get some additional studies. But at any rate, this is basically a picture of what a cervical rib looks like, and you can see the arrows pointing to the cervical rib. He actually has bilateral cervical ribs, by the way. He or she, I can't remember if this is a he or she, but at any rate, you can see that it's sort of, sometimes it's quite a subtle finding, and in this case, it's really not. But again, without a chest X-ray, you know, it's cheap and easy and very little radiation, and there you have it. Now, MRIs. MRI is a wonderful tool. It really is. They are phenomenally good for soft tissue imaging. They can show compression, they can show veins, they can show vessels, they can show nerves, and they are useful. The problem was that the older 1.5 Tesla scanners didn't really have good resolution to show us what we really wanted. Now, there is some evidence being gathered about the 3 Tesla scanners that they may be of greater predictive value in who has neurogenic thoracic outlet and who doesn't. Now, there's been a couple of studies, and the one that I was looking at was in Baumer et al. I think he's out of Michigan, but I'll have to check that camera looking at me, so don't, yeah. All right, so the 3 Tesla MR neurography is actually fairly useful, and it can actually even show fibrous bands and discern certain anatomic defects that you wouldn't necessarily see. Now, this study showed 7 out of 30 patients with unambiguous findings that were morphological correlates of thoracic outlet syndrome, which were verified on surgery. Now, as anything like this, the devil is in the details, because number one, you have to define what is an unambiguous morphological correlate, which basically was an anatomic finding in this, but everybody has different definitions. And then who did you take to surgery with what you're calling thoracic outlet? However, again, it's a subjective disease with subjective evidence, and this is as good as anything. You can see here, these studies are absolutely excellent. These are images taken with a 3 Tesla scanner using MR neurography. And what you're seeing here is one of the trunks of the brachial plexus. There's the C7 and C8 trunk, and you can actually see, I believe that's the neurography showing compression. And it's a little difficult to make out, but that band is around the anatomic problem. I believe, and don't quote me on this, but I believe that was a scalene minimus muscle, which is clearly compressing the roots at the point where the neurography showed it would. So there you go. Now, there's still no hard criteria when you use an MRI. So you will get reports from an MRI that says, suspect thoracic outlet syndrome, but it's not like an aneurysm. So it's not like I can scan your belly and say, you have a 4.9 centimeter abdominal aortic aneurysm. And we know that we have to fix these by 5.5 centimeters, otherwise it'll rupture and you'll die. We don't have that with MRI, okay? It just doesn't work that way. And I think that people who would say that it does, again, they may not be correlating this clinically with the patients they're seeing, because I could probably scan all of you and who knows what percentage of people would come back and say, hey, that guy's got thoracic outlet syndrome. But at any rate, I think what it can be is a useful adjunct to surgery in a complex case. And I've never shied away from ordering a study where I think it's going to help me in the operating room. I like the adage, it's always better to have and not need than to need and not have. And that's how I look at MRI. Now, what you're seeing here is one of Saddam's many palaces that were scattered all over Baghdad and all over the country. This one I found particularly beautiful, and it was nested on a lake, and you can see that it's really, really nice. And inside was as nice, because you look at this, and that's just a faucet in the bathroom. It's dolphin-shaped, and it's really nice stuff. And what often happens when you leave your stuff alone and you don't keep an eye on it, people will come in and use your stuff. There you go. So that's me sitting in a very expensive chair and looking like I know what I'm talking about, I guess. But anyway, the entire inside of that thing was as ornate as you see. It's a fascinating experience. I'm not sure what became of the chair. So studies continuing. CT scan, essentially, I'll just say, is worthless, okay? CT scan for thoracic outlet syndrome, neurogenic, worthless. Arterial, excellent, absolutely excellent, and essential for making a correct diagnosis and planning an operative intervention. For venous, so-so. Although if you're going to go venous, you would probably just shoot a venogram, which will be better for you. But there's a little bit, I won't even really kind of go deeply into the studies that say it may be useful for neurogenic, because I just haven't really found this to be the case. But again, it's really, really, really good for arterial. And this is actually a patient that I took care of in Iraq. We did have a CT scanner, and it's to this day the nicest example of a post-stenotic dilatation with an aneurysm with thrombus in it that I've ever seen. You can see the arrow pointing at this little guy here is actually the first rib. This is the cervical rib, which had inserted down into the first rib in a bony protrusion. The artery rode up over it. This is an aneurysm, and this is thrombus. And the way this gentleman presented to us was with a cold hand, all right, and occlusion of his brachial artery. And he was what we referred to as a bomb thrower. So he's a bad guy, but we fixed him. I think he did well. But at any rate, he required a repair, and I'll show you that later. But as you can see, the images are really excellent. So nerve conduction. Now, I can tell you that when we send patients down for nerve conduction studies, I kind of get the feeling that they're sorcerers down there, and they hook up all kind of stuff and say magic words, and we get results back, and then that's the nerve conduction study. But again, as this is sort of my business, I try to familiarize myself with the tools at my disposal. So this is more for vascular surgeons than it is for you guys, because I think you'll be a little more familiar with nerve conduction studies, but motor nerve conduction, sensory nerve conduction, and F-wave. And we look at all of these things to sort of figure out if there is a peripheral element to the neurologic phenomenon that the patient is experiencing. Now, again, I'm not going to go too deeply into this stuff here, because I think you guys are all pretty familiar with it. But this is really these are the reports that we're going to see at the end of it. And the question is, what is it telling us and what is it not? Because we all like to get, or a lot of folks will like to get nerve conduction studies in a patient with thoracic outlet syndrome. Now, it turns out that they're not really useful, except in a couple of rare instances in which I'll discuss. What they are probably most useful from my standpoint is if you suspect that there is something else going on, then a nerve conduction study may elucidate that more readily than just like a physical exam and a history. Especially if it's if there have some systemic complaints going all on as well with that. There have, however, been some studies, and the first one was out of France by a gentleman named Serrar, if I'm pronouncing that correctly, I hope. And what they looked at was the median antebrachiocutaneous nerve latencies. And the median antebrachiocutaneous nerve is a sensory nerve that runs along the medial aspect of the arm. And for vascular surgeons, mostly it's a pain. Okay, the reason it's a pain is because when we do what's called a basilic vein transposition, we take the basilic vein, harvest it from the medial aspect of the arm, and swing it over, and reattach it to the artery, and create a fistula for dialysis access. It's always in the way. Okay, it's sitting there, and it sort of syndactylizes over the vein, and you have to be careful, not to damage it, or your patient will get a profound sensory loss at its sensory distribution. So we do our best to preserve it. Well, it turns out that particular nerve may have some interesting abnormalities with thoracic outlet that sort of point you to in the direction of that diagnosis. Now, Taso followed that study up with a much larger sample. I believe it was like 50 patients, and found uniform evidence of a chronic axonal loss that affected the lower portion of the brachial plexus. And the T1 and C8 sensory motor fibers were abnormal in about 89% of the patients he studied. Now, that T1 or C8T1 is, again, that ulnar distribution. So as it turns out that many patients with that inferior trunk and root compression can have abnormalities here. Bennett, vascular surgeon, Annals of Vascular Surgery, looked at sensory latencies and found that in controls they were 1.5 to 2.4 milliseconds, whereas you look at neurogenic thoracic outlet patients, they were elevated to 2.2 to 2.8 seconds. So there's probably a difference there. And what was more interesting is that these patients were different from side to side in their own arm. And what is a better control than yourself? Okay, so another little distraction. I am a general surgeon as well as a vascular surgeon. And when you're in an environment like Iraq, you don't have access to a lot of things that we sort of take for granted in the real world. And one of those is an interventional radiologist. Now, this young man is a subcontracted employee from one of the Halliburton subsidiaries who came over and was being paid about $10 a day to cook food. These guys would not go to sick call unless they were essentially dying, and this is where we found him. And he had a ruptured appendicitis, which I figured, yeah, sure, I'll give it a shot and drain it. And you're seeing the drainage from that guy right over here. And you don't have to imagine what it smells like, because my corpsman can show you. All right. So that was just another interesting thing that we did over there. So how do we treat neurogenic thoracic outlet? Physical therapy is the first line treatment in all of these cases. All patients get physical therapy, and it depends on how you protocol it. My personal protocol for these folks is 2 6-week blocks, and they have to fail both of them. Depending on the study you look at, about 80% of these folks will get better with physical therapy. I think the number most of us find is closer to 50% will be able to get better and avoid surgery. Unfortunately, it is those very people who respond well to physical therapy who probably will respond better to decompression, but that's just the way it is. Again, people who don't get better are candidates for surgery, and it behooves you to kind of get to know your physical therapist and PM&R docs so that we can sort of establish a relationship. And when I send these folks, they get directed therapy towards thoracic outlet, which is important. Now, I personally have undergone that because I wanted to see what it would be like, to check it out. So, when I send these folks in, I can bring them back and I can ask them, what is it that they're doing with you? And if they show me that they're doing the correct exercises, then I feel better about it. But there's a lot of places out there that just kind of, don't know what they're doing, or will do what they feel is right. And you need to kind of weed those out. How do we treat it? Again, there's been some talk about Botox injections. Botox, great stuff for wrinkles. I mean, what doesn't it do, right? All right, so you actually have 3 studies here. Jordan et al. Had a 50% reduction in symptoms, 14 to 22, about 64% of his patients. But the effect was limited duration, about 3 months. Torani had ultrasound-guided approach with about 31-day improvement average. The best study was Christo et al. Had a guided CT chemodenervation of the anterior scalene muscle, which actually did pretty well with durable pain relief at 3 months. But as you can see, I mean, when you have a patient who's been suffering from this thing for years, 3 months is good. and if you want to send them in and get a temporizing measure, I think it's an excellent idea. But it's not going to fix their problem forever. All right, just like the wrinkles will come back, so does the neurogenic thoracic outlet syndrome. Now, what I found it more useful for, in that to include, which I didn't really mention here, is a scalene block using a temporary neuromuscular blocker, would be more of a diagnostic tool. So if you have a patient who's presenting with symptoms primarily pain-related, and we give them a injection of Botox, or we just do a standard scalene block, and all of a sudden, wow, doc, yeah, my pain is gone. That patient goes to the operating room because I know that I can make them better, okay, and their pain's going to go away. Because again, that pain can be extraordinarily debilitating. So how do we get these? What do we do in the operating room? Well, it turns out surgery is an excellent modality. All right, it's probably of all the procedures I do, it's more of one of the technical demanding ones. But if you've done some, you can do it very safely, very effectively, and you can make patients better. The two approaches that everybody uses essentially are transaxillary, excuse me, underneath the armpit through a small incision, or supraclavicular. There is a growing, robotics is out there, okay? And it's one of the things that I personally would like to do some more, but I don't think it's necessarily any better for the bulk of the work, and certainly not for neurogenic. Probably its role will be limited to vascular phenomenons. Because in a neurogenic, you have to have a complete neurolysis, and it's very difficult to do with the robot from that angle, if it's at all possible. Axillary, most people used to do it. I won't go too deeply into this, but it's a very difficult approach, and you do not want to be the first assistant, because you'll be standing with a hook like this for about 3 hours, depending on how quick the attending surgeon is. And I don't think you can perform the vascular reconstructions as well through that little incision, that's just not what I was trained to do. So supraclavicular, okay, I'll give it to you. It's less cosmetic, but the incision I use is this long, so okay, if that's going to be your greatest concern, then I guess we can refer you to somebody who does the transaxillary. But most of the time, it's just not. People don't care. Just like, please fix this problem. It does give you phenomenal visualization of pretty much everything you want to see, including the phrenic nerve, including the long thoracic nerve, including the roots and trunks of the brachial plexus. And oh, by the way, if you want to do a vascular reconstruction, it's right there. A view of the subclavian vein is a little lacking, but that can be greatly improved with counter incision inferiorly. In fact, you can get superior visualization down there as well if you want it. And you can get a perfect neurolysis. And I think that the key to this operation is a very gentle and good neurolysis. So this is actually an intraoperative photo from one of my patients, just to orient you. This is lateral, this is medial, so the sternal notch is right around here. What I've done already is I've transected the clavicular head of the sternocleidomastoid. That can be reapproximated very easily just using some heavy vicryl sutures. And even if you don't reapproximate it, it'll sort of scar in by itself, and you lose no flexion of the head and neck. This thing here is the phrenic nerve. It always lives there, right on the anterior scalene. That's just where it is, okay? So we always like to find that. It's the very first step in the operation. What you're seeing here, and I'm putting a little extra traction just to demonstrate all the structures here. I think that you've got to be very, 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 very careful with nerves when you're operating around them. Nerves are finicky things, and if you do things to nerves, they will make you very sorry that you did them, all right? So especially the phrenic. The phrenic, if you sneeze at it, it'll paralyze the diaphragm for 3 weeks. Now, that's not such a big deal, because even in a young, healthy person, if I cut your diaphragm, you're only going to lose about 15% of your pulmonary capacity. But if you can imagine that you're an old COPD or something like that, that's going to be an issue. Not that those would be the patients in this case, but just in general. You're seeing here, interestingly, a little accessory phrenic nerve, and that's not a terribly uncommon finding. You can sacrifice it if you need to, but I like to preserve that because I kind of think it's there. It's probably there for a reason, so we leave those things alone. But you can see here that this neurolysis was extensive, and in fact, roots, trunks, and you're actually already out to divisions, and you can see that very well here. This is that patient with the supraclavicular aneurysm. So I had resected his first rib at this point, and now I'm staring at this thing, and that's the aneurysm that you saw on the CAT scan. And what we did basically is just take that out and did a little saphenous vein interposition graft. So, you know, it looked real pretty and it was fun. There you go. So as you can see, though, that the exposure is great for vascular reconstructions. Now, this is all absolutely of all time my favorite quote in medicine. Now, I wanted to put this on all of my consents, but they won't let me. So, you know, all who drink of this remedy recover in a short time, except for those whom it does not help, who will all die. Okay, fabulous. All right, so anyway, we have a version of this too. Okay, and there it is. All right, so the question I'm trying to throw out there, guys, is surgery. Does it work, right? I mean, does this work or does it not work? Well, it turns out it does, and we're getting more and more evidence that it does. Okay, so I've just listed a series of studies here: fact or fantasy, 409, Canadian, like 78%. Outcomes after surgery, thoracic outlet syndrome, 2001 out of Ann Arbor, 65% improvement. These guys in France are killing it. You know, they're 92% improvement. It's that's great. I got to go over to France and see what they're doing over there, and I intend to someday. And then out of Baltimore, a woman named Julie Freischlig, who is sort of was the bigwig for thoracic outlet on the East Coast, who has now moved back west. She put out a lot of studies that had significant improvement in these folks. And then more recently, there's even some more evidence that's coming out. Now, you know, the question is, as in any surgery that you're doing for some subjective symptoms, who can you do it for which it will help, and who can you do it for which it won't? So some of these studies did break down into sort of high performance groups, or patients who are more motivated, shall we say. And this is one of them. Looked at, they actually had a subgroup of 27 neurogenic thoracic outlet patients. 22 of them got better, about 81% successfully returned to full activity. This is another study with a subgroup analysis. I won't go again too deeply into this, but again, it looks like maybe highly motivated patients will do better. So, and you guys are going to have to allow me a little vanity, okay? So when I was in, by the way, the second one's coming out pretty soon. So one of the things that we had access to when I was in the Army is that you know, we have a fairly homogeneous patient population. That's why people study veterans all the time. Veterans this, veterans that. These study that studies. And what it amounts to is that people in the military are looked at as more of a homogeneous population as people in a civilian setting, as essentially they should. But what we wanted to find out was if we were to take a subgroup analysis of patients who are soldiers, basically, who we would consider to be highly motivated individuals, will they get better with the operation? So basically, we looked at our subgroup of patients who were actually active duty soldiers of any variety. We didn't break it down by combat role or anything like that. And then we looked at them and we looked at how they did with a neurogenic decompression. Our hypothesis was that they would get better with a decompression for neurogenic thoracic outlet. And we wanted to demonstrate that improvement. We used the DASH study, Disabilities of the Arm, Shoulder, and Hand. I'm sure if you haven't seen it, you will. I would suggest that you just look and flip through it, because a lot of the evidence for orthopedic surgery is taken directly. They use the DASH all the time. And they also, this is just, you know, a picture of what you'll find. It's just a bunch of questions as to symptoms and function, and then the CBSQ, Cervical Brachial Symptoms Questionnaire. And again, it's sort of the same thing, but we used both studies to increase our sensitivity. We identified 35 subjects from 2009 to 2015. 20 responses were obtained. Considering the transiency of our population, we felt that that was a pretty good number. And considering the contemporary studies, none of which really had that pure of a subgroup, it's actually a pretty good number for us. And again, what we found was these patients were kind of right down the fairway as to who had it and who didn't. 60% female, 40% male, and they were about the right age. And I won't bore you with all of that stuff. What we essentially got is that 85% demonstrated considerable improvement. And we have here basically pure score reductions from both the DASH and the CBSQ. These are just percent changes in the total DASH and the total CBSQ. And this is our research basically broken down by function and symptoms in the DASH and the CBSQ. And you can, shoe fly, you can see that there were significant score reductions across the board. So you know, we were very, very happy with the results. Hopefully we'll get this published in JVS relatively soon, being under reviewed at this point. But the point is, at the end of the day, what we feel is that neurogenic thoracic outlet syndrome, it's out there and it's a much bigger player than people think. There is no major referral center for the Philadelphia area, and now that some people have left, you know, we'd like to kind of fill that void. So what we're starting at Temple is we're trying to put together a neurogenic thoracic outlet center, because we'd like to do all of these in the region, and it's certainly something that we're excited about. And long story short, if you come across these patients, send them to us. You know, and you can call me personally. All right, and I've got a cell phone and it's listed. And if you have any questions or any concerns or anything like that, just send me the patients. Okay. And I will help you get these guys sorted out. So, long story short, it's out there. It's a problem that is vexing to many, many, many people, and we think that treated correctly, it absolutely can be fixed. I have many, many, many references. I'd be happy to provide them. Here is my question slide. This is what we do as vascular surgeons every day, okay? So it's basically just trying to fix the plumbing while the water's running. So that's how I feel all the time in the operating room. But yeah, sometimes it can be fun too. So with that, I'll take any questions.
You said neurogenic is 95%. Is there a quick and dirty way as a resident to figure out which is which? Yeah,
I mean, the vascular are going to present very, very differently. Okay, a patient with, like, for instance, an arterial embolization is going to present. They're going to show up with a cold hand that they can't use. All right, it's going to be blue. It's going to be weak. They're going to have paresthesias. They'll be pulseless, just like a lower extremity would. You know, if it's a venous phenomenon, a Paget von Schroeder's, or what we call an effort-induced thrombosis, then basically what you've got is an occlusion of the subclavian vein. Those patients will present to you again in a spectacular fashion. They'll come in with a massively swollen arm. All right, it might not necessarily be at risk, but it'll definitely be uncomfortable for the patient. Everybody else, all right, will come in with these vague complaints, paresthesias. It's all on the slide deck, you know, but you know, hand weakness, arm pain, shoulder pain, occipital pain radiating to the head, and they may have some of them, they may have all of them, they may have some at one point, and then it's worsening at another point. You know, the deal is it's nebulous. It's just nebulous. And again, that's why you kind of give the presentation. You get the word out that this is out there, and then people know what to look for. But you know, that's basically the size of it. So you will not have difficulty differentiating, because the other two will present quite acutely.
Sure, but like the workup, just a chest X-ray to look for anatomic abnormalities. Other than that, the initial workup before calling you.
Yeah, honestly, if you X-ray and you do a history and physical and you send them, I'll do the rest. Okay, because when I see them, everybody will then, you know, they get my history and physical. And everybody routinely gets an ultrasound of the thoracic outlet just to make sure that there's no vessel involvement, because it figures that if you had a lot of scarring and damage to the thoracic outlet, there probably could be anyway damage to the artery of the vein, and you want to rule that out. Usually older women will get cervical MRIs just because the hit rate for cervical cord compression is usually a little higher in women than it is for men, especially older women. But honestly, don't go nuts. You know, if there are other things that we need, I just order them up and, you know, take care of it.
So there's specific exercises you look for once you're doing therapy. Specific?
Well, not going too nuts, but you know, because again, there's a whole, you could probably do a whole lecture on thoracic outlet pathology. But really, what you're looking for is things that sort of loosen up the thoracic outlet. So, for instance, if your patient is just doing a bunch of exercises to strengthen their arm, they're doing the wrong stuff. Okay, but you know, I'm not going to go too crazy here. But yeah, it's things that will open up the outlet. So, for instance, if you put your hands on the wall, and then you can just sort of lean forward like this. And as you can see, this sort of distracts the shoulder away from the midline and opens up the outlet. You can lay on the ground with a towel and pull it, you know, up and back behind your back. You can do exercises where you can sit on the edge of the table, and again, just slowly go forward and loosen your outlet. Maybe I've got a little neurogenic here. have to stop because I might have to operate on myself. But at any rate, any good PT or PM&R text will have a huge list of thoracic outlet exercises that you can look in some detail. And you know, usually I'll either directly contact the physical therapist to discuss it, or just make sure that I send them a protocol that I have. So.
Why do you think the lower trunk refers into the hand and the upper trunk refers into the ear and the neck?
Just because that's where the sensory distribution of those are. So if you think about where the C8 and the T1 nerve root and the ulnar distribution is in the hand, right? The upper distributions will control the sensation in the lateral arm. Anterior chest is upper, posterior back and shoulder upper. So it's just all the sensory distributions of the brachial plexus. Fair enough. Yes.
So since symptoms often are positional, is there utility in doing conducting studies in positions that bring up?
I can't answer that question, to be honest with you. I don't know. I don't even know if that's really been looked at. Possibly. All right. Thank you very much.